Welcome everyone to our panel discussion today on addressing and assessing equitable access and distributive justice in global supply chains during major disease outbreaks. In his opening remarks to the 148th Executive Board of the WHO, Director General Dr. Tedros stated, and I quote, "But we now face the real danger that even as vaccines bring hope to some, they become another brick in the wall of inequality between the world's haves and have-nots. It's right that all governments want to prioritize vaccinating their own health workers and older people first. But it's not right that younger, healthier adults in rich countries are vaccinated before health workers and older people in poorer countries. It's against this backdrop that we are asking the question today on the panel, are we all in this together? Let me begin by introducing to you our esteemed list of panelists. We have Alicia Yamin, lecturer on law and senior fellow on global health and rights at the Petrie-Flom Center for Health Law Policy, Biotechnology and Bioethics at Harvard Law School. She's also senior advisor on human rights for Partners in Health. We also have with us Dr. Tsion Firew, assistant professor of emergency medicine at the Columbia University's Vagelos College of Physicians and Surgeons. She's an emergency medicine physician at the NewYork-Presbyterian Columbia University Irving Medical Center and special advisor to the Ministry of Health of Ethiopia. We also have with us Benjamin Meier, who is an associate professor of global health policy at the Department of Public Policy at the University of North Carolina at Chapel Hill. We have with us John Monahan, professor and senior advisor to the university president at Georgetown University. Diane Desierto is professor of law and global affairs and the faculty director for the LLM program at the University of Notre Dame. We also have with us Carter Sneed, who is professor of law and director of the De Nicola Center for Ethics and Culture. He's also a concurrent professor of political science at the University of Notre Dame. We'll begin with Alicia. Alicia, if you could give us a quick overview and answer for us this major question: what needs to change in global health to ensure fairness and equity?
Well, first of all, thank you so much, Sarah, and thank you to the organizers at Notre Dame for inviting me to participate in this important webinar. I had proposed to Sarah when she initially asked us to do this that it would be good to tether our discussion of what is normatively required in terms of distributive justice to some empirical realities. So please show the slide. I'm going to base some of my remarks on the work that I do with Partners in Health, which is a global social justice organization that focuses on getting high quality health, public health and health care to people around the world with a preferential option for the poor. So these are the places where we work. We also have a US public health accompaniment unit, which works across the United States in states from Massachusetts to Illinois to Newark, New Jersey to Immokalee, Florida. And just to give you an idea of how much granular information is necessary to assess justice, in the state of Massachusetts, where I currently live, we have 351 public health departments, which of course speaks to enormous fragmentation of our health system, but also the need to really understand what is happening in different contexts. So having said that, I'm going to try to give three top line findings about what are issues in global health equity and supply chains. And they are international distribution, local manufacturing capacity, and health system strengthening. So the first point is international distribution, where we don't know enough, certainly, but we do know that export bans and import bans have been a major obstacle in this pandemic, including on such things as personal protective equipment. It also points to an insight that I'll talk about later on, perhaps, which is the need for technology transfers, because of course, technology transfers are not subject to import-export bans. I think it has also become clear that, examining pandemic preparedness by country is very insufficient because international distribution channels are dramatically disrupted. And in this pandemic, it has become clear that logistics efforts such as the air bridge through the UN logistics cluster and the World Food Program have been dramatically underfunded. A third insight, I think, is that we need much more information to establish, but also to monitor strategic stockpiles in low and middle income countries, and probably regionally, not just country by country. And similarly, we need much more transparent and comparable information to study the pricing and how purchasing power in different places is being translated into inequitable allocation. A fifth issue in international distribution is, of course, vaccine nationalism, which is top of mind now. And it's clear to us, Partners in Health is a member of the People's Vaccine Campaign, that this is not a question of rich countries donating a few more crumbs from COVAX, but that the COVAX facility itself was absolutely poorly designed from the start and radically inadequate. And we need to think about CTAP and other mechanisms in conjunction with to waive temporarily intellectual property rules in addition to ramping up manufacturing capacity. And manufacturing capacity is the second issue. I think local and regional manufacturing capacity, not just for the vaccine, but for diagnostics and therapeutics, it has become glaringly apparent that these are inadequate. And again, so donating fully formed vaccines to other places in the world is an inadequate response, because we should be investing in manufacturing capacity now so that it's not a perpetual cycle of dependence of low-income countries on high-income countries. And the third takeaway is health system strengthening. Partners in Health, the places in which we work, which you saw in the first slide, have done reasonably well, remarkably well by comparison with other areas, because we invest so much in health system strengthening when there are not epidemic outbreaks and emergencies. And we work consistently with ministers of health because that's really the only way to do adequate health system strengthening long term. So I'll stop there, and I'm happy to answer more questions later on.
Thank you, Alicia. And I think that mention of Partners in Health working with ministries, government ministries, to make sure that health systems are strengthened is a good segue to ask Tsion to come in and also add her comment and perspective on the question about what do we need to change.
Thank you for that, and thank you for having me on this panel. And I think Alicia outlined most of the some of the solutions that I also agree with, and some of the things I think to add to it, especially what we learned from this pandemic, really is that representation matters at the decision table, whether it's at the UN or the WHO level, and also at the implementing and other partner organizations. And I will also unapologetically say really having more women at the decision-making table, as we've seen in during this pandemic, having women leaderships has proven to be exemplary, especially in places like in New Zealand and Germany. And most of the leadership here in Sub-Saharan Africa has been led by women ministers who have taken such a collaborative effort. And also, I think during this pandemic, we've seen really how the gap has been widened, especially when it comes to people that are at the decision table, when it comes to the vaccine distributions, and lack of representation also in the experimental and doing the experiment for the vaccines. And I absolutely believe that we need more representation of the global South at the decision table, as we need to amplify the voices of the people that we're trying to help. And I would say this before the pandemic, especially walking into UN high-level decision and other side events that are at WHO or UN level. Sometimes I kid that I'm not sure if I'm walking into an international meeting versus into an orthopedics ground round, because most of the people on the table, or as a panelist or as the ones that are contributing to the decision table, is just a homogeneous a representation. And really, if you're trying to design an impactful program, you need to have people who know the ins and outs, who know the challenges on the ground, who also know some of the gaps and some of the solutions that are represented can be very asymmetrical, coming from a global north and really minimizing the voices of the people from the global south. So these are some of the things that I would really suggest. And before the pandemic, what we've seen, most of the approaches towards a solution to when partners come into low middle income countries is really vertical. And as Alicia has mentioned, and I really agree with the goal of health system strengthening, what we've seen in most places before the pandemic, ending the pandemic, this vertical approach is not sustainable. It will contribute for the time being that the partners are involved in the country, which in the long term would lead to some unintended consequences and implementation programs that we have designed for those specific countries. So I'll stop at that.
Right, who gets to be at the table is important. And Diane, I'll turn it over to you from that point. Who should lead the consensus of public health then? Who should be the one making sure that there is equitable distribution in times like these?
It's an interesting question, Sarah, and thank you to the Eck Institute for the invitation to be part of this event. In the first instance, I'll invite everybody to remember that in April 2020, the Secretary General of the United Nations declared that the United Nations response to COVID-19 was supposed to be not just an act of solidarity, but most importantly, one that's premised on international human rights law. That the entirety of our responses, whether they be epidemiological or logistical in any fashion, should consider first and foremost the continuing need to ensure the realization of human rights in all populations in the world. It's a global emergency, make no mistake. So who should be taking the lead? I'd say states should be taking the lead right now in concert with the rest of the nations of the world, and taking into account four interrelated legal dimensions in resolving this distribution and access problem. If this is a global emergency, it's quite curious that the fragmentation of international law and the fragmentation of international decision makers is contributing to the gridlocks that we're seeing in today's problems regarding distribution and access. We spoke earlier about and made mention of trade rules and intellectual property rules. In March 2021, the TRIPS Council will deliberate on India and South Africa's proposal to encourage WTO members, World Trade Organization members, to issue a waiver to ensure and enable compulsory licensing of the current vaccines, the efficacious vaccines, especially for lower income countries. The stumbling block there is that the United States, as well as its partners in Europe, have indicated that they will resist any attempt to try and enforce any waivers in this respect, unlike the waivers for essential vaccines that were reached by the WTO or issued by the WTO in 2005. This time around, the pushback from the European Union, as quoted in one news report, is that there is no evidence, so to speak, that distribution and access is being impeded by intellectual property rules. But that's a factual discussion to be had. And even within the auspices of the World Trade Organization, it is not a public deliberation that is being made. The TRIPS Council deliberations will certainly not be open to the public and certainly not be open to the wider community of stakeholders in global public health. The second dimension that I want to refer to, where all states have a stake, is also human rights law and information transparency. Alicia very rightly pointed out vaccine nationalism being an issue. The de facto situation that we have here is that the developing world is being asked to wait for 2 more years, conservatively before they could get vaccine coverage. Under the present scenario where most of the world is under a state of emergency and there is a normalization of human rights violations taking place in most of the developing world, 2 more years of this, at this most conservative estimate, is an unconscionable situation for the international system. And that's certainly a failure of the legal dimensions of enforcing human rights law behind every strategy to deal with COVID-19. And finally, the last 2 I'll point to is international cooperation has been framed in existing platforms of cooperation as a voluntary obligation, or rather a voluntary initiative on the part of states, but they do forget. They do have international cooperation duties under the very same human rights treaties that they've signed, most specifically the International Covenant on Economic, Social, Cultural Rights. So rather than frame this as a matter of charity or as a matter of volitional participation, this ought to be seen and reframed as a standpoint of international obligation for which all countries that are parties to these human rights treaties do bear responsibilities. And finally, the less discussed aspect is how important legal enforcement and accountability is at this time against morally hazardous behavior, against the black markets that have arisen in regard to PPEs, in regard to vaccines, and fraudulent behavior, so to speak, preying upon those who are seeking vaccine coverage, but who are unable to authenticate whether they're actually getting vaccines in various parts of the developing world. We're seeing a steady rise of these cases, but in the absence of a concerted global effort under the auspices of the United Nations, under the multilateral system in concert with all states, we're not going to see any significant response based on the legal dimensions, the 4 legal dimensions I've discussed.
Thank you for those remarks. A failure in global coordination, a failure to adhere to international human rights standards and obligations that states have made. Any comments from other panelists on this particular question, and really about who should be leading then the consensus? What can be done based on what Diane has raised? Yes, Ben, I see that you've unmuted your mic. Go ahead.
As we think about these issues and we focus on specifically the TRIPS waiver and whether we should allow the TRIPS waiver to be employed, what role can human rights play in WTO decision-making? So when countries come together through the TRIPS Council, to what extent is the WTO or member states of the WTO bound by human rights obligations in their decision-making? And I'm hoping Diane can, I don't know if this is a question or more of a comment, but I'm hoping that Diane can speak a little bit more to this relationship between international trade imperatives and human rights obligations.
If I could respond briefly to that, thank you very much, Benjamin, for the question. For quite a long time, WTO members have preferred to look at WTO law quite hermetically without looking at their parallel obligations under human rights law. We've increasingly found, at least within the last 10 or 15 years, a growing convergence, or at least attempts by many states to bring in their human rights obligations in tandem with the reading of trade obligations. And so while there are arguments to be made within the trade law regime, such as take advantage of GATT Article 20 national security exceptions, or what some have said in regard to the TRIPS agreement, the Article 73 flexibilities for possibly relaxing the current rules to enable more massive domestic production or importation of more cheaply produced generic versions of the vaccines, that's human rights law is not even being brought in. India and South Africa have tried in their submission before the TRIPS Council, but as to whether or not that's even going to be persuasive to the TRIPS Council and to the member states that comprise the TRIPS Council is an open question. In the first place, none of us will get to watch what goes on in those proceedings. And yet all of us are supposed to be constituencies of those same human rights obligations of states.
Thank you.
Yeah, and this is a great way again to move to Carter, who's been in these kinds of situations, right? Where states are coming together, negotiating, talking through. So Carter, what do we do? Can we find a model for unanimous consensus in response to disease outbreaks for more equitable distribution?
Yeah, well, first of all, I'd like to echo my colleagues' thanks for inviting us and to thank the co-panelists for their thoughtful remarks as well. This particular question of vaccine allocation and distributive justice is a little bit outside the ken of my usual work, but as you say, I do have a pretty extensive experience in intergovernmental fora negotiating on behalf of the United States government or as an independent expert on bioethical questions and questions that touch and concern distributive justice and access to essential medicines and related matters. And so, for example, I led the U.S. negotiation for the Universal Declaration on Bioethics and Human Rights in the early 2000s, and then worked at the Council of Europe as a permanent observer and worked on the Intergovernmental Bioethics Committee and the International Bioethics Committee. So I've heard a lot of, of disparate perspectives in those settings that echo and track, I think, the issues that we're encountering here. And listening to my colleague Diane talk about the sort of a lot of industrialized countries blocking humanitarian sharing with the developed world in the name of sort of commercial interest or protecting commercial interest, something that we experienced and had to deal with directly in my own negotiations, especially on issues of intellectual property or other related matters. And there were two strategies that we used in those settings to try to overcome those difficulties and to break that gridlock. And one of which was pursued by the Secretariat of UNESCO at the beginning of the debate, which is to say they sort of surveyed all of the member states and asked them at the beginning, which basic first order of principles can we all agree on that we can refer back to in our conversations about concrete and granular policy matters. And I mean, convincing a state or even convincing a person that it's unjust, and I agree entirely, Sarah, with your original comment, that it's not fair for the healthiest in a rich country to have access to essential medicines and vaccines and interventions when the weakest and most vulnerable elsewhere do not, right? But we have to figure out a way to explain that in a manner rooted in first principles that gets wide consensus. And and so they sent out a questionnaire and at least took the sense of the room as to what first order normative principles most appeal to the member states themselves. And then we can build an ethical argument as to why you have an imperative, both in justice, but also in mercy and friendship to share with the weakest and most vulnerable among us. And so it was in May, they did a questionnaire and they came back and everybody voted for human dignity. Everybody voted for solidarity. Everyone voted for the intrinsic equal dignity of all people. Now, we didn't, as in the original negotiations on the Universal Declaration of Human Rights, didn't get probed too deeply as to why people care about human dignity or what the grounding for that is, because then things can break down pretty quickly. But at the very least, at that level of workable discussion of principle, there was useful conversation when we talked about things like access to essential medicines and traditional knowledge and the needs of indigenous peoples and biopiracy and all the other questions that were matters of concern for the bloc of developing nations as a negotiating bloc. And that's sort of at the level of high principle. That was a successful strategy ultimately in getting consensus. UNESCO, as you probably know, operates by consensus. They don't vote on these questions. It's considered very bad taste to call for a vote in those settings and uncollegial, and so no one ever does. But the other interesting thing, this is a more kind of tactical strategy that worked, was to, even for those like the United States, and this was true across administrations. It was true when I worked during the Bush administration. It was true when I worked during the Obama administration. The State Department has sort of entrenched positions that they're not willing to admit to new rights. They're not willing to accept new rights. They're not willing to allow new to commit to new propositions that will interfere with the settled interests of probably mostly our domestic, business interests. And so what we did instead is, rather than trying to force the State Department to agree to accept the proposition of new rights, right to health and other things, we instead went back to the documents that they'd already agreed to, including the WHO Constitution, and talked about the obligations of nation states towards their citizens and towards one another. and language they'd already agreed to, and they reaffirmed and reiterated the really great language they probably wouldn't agree to now if it were presented to them as a matter of first impression. And it actually worked as a good point of leverage to allow the U.S. delegation and our partner delegations to agree to things that the institutional interests at state and elsewhere weren't excited about, in exchange for other language from the developing world in the negotiation. So I think there's both a kind of high principle strategy, find those areas of overlapping common ground at the level of normative principle, but then also don't be afraid to look and see what you've agreed to in the past, which might very well have direct resonance and application to the things that are on the table now.
Thank you for that, Carter. Human dignity, right? All the countries can agree to human dignity, and they can agree to the importance of human life. So are there any more comments or questions from other panelists related to this particular submission by Carter? Yes, go ahead, Alicia.
Thanks very much. I of course support what other colleagues have been saying, but I do think that it points to the need to complicate the discussion of rich countries giving a certain amount of leftovers to poor countries after we've dealt with vulnerable populations. At Partners in Health, we deal with vulnerable populations within the United States, including incarcerated populations. And it's not at all clear that, oh, well, we can give the vaccines after we deal with everybody who's 75 or above, or maybe it should be 65 or above, or maybe it should be people who are 65 and above and who have comorbidities. Maybe it's, so it's not at all clear exactly what the cutoff should be to give the vaccines away. And it's likely the way this thing is playing out that the most marginalized and vulnerable populations, including possibly people who are incarcerated or homeless or undocumented immigrants, would suffer in those cutoffs. We know that chronological age is a proxy for physiologic age. So actually the age cutoffs have a de facto discriminatory effect against people of color. We also now know some more about the different vaccines. We know that the AstraZeneca does not work well against the South African variant. The AstraZeneca was the vaccine that COVAX was betting on. We know that Sputnik V is based on the AD5 vector, which may have really disastrous consequences in populations that have high HIV prevalence. So I think it's more complicated than encouraging rich countries to give excess to poor countries. And we really need to think about the structural solutions that lie in intellectual property and supporting local manufacturing capacity.
Any other panelists? Thank you so much for that, Alicia. Any other panelists that want to comment? Tsion, go ahead.
I really appreciate what Carter had outlined, and most of the things, especially at the UN and WHO level, and also what Diane's really spoke at WTO level. And I think what I am seeing as a common theme is that most of the member states or the countries are not living by their word. And unfortunately, the accountability framework has been very difficult to implement. So my question, because this is something that I always battle with to anyone, anyone on this panel, is how do we make most countries, especially the developed countries and the high-income countries, how do we hold them accountable, especially with the transition of power and with elections happening, because whatever one prime minister or president committed to next time around is going to be thrown, under the rug. So I just want to kind of ask, and also because it's always a difficult thing for me to bring up as a discussion, and we see this mostly as developed countries have a change in their leadership, and we really do hope that the leadership as representation of the people of that specific country, but of course a change with the political climate. So what is it, and what can you do as citizens, academicians, or as people that live in those places, how do we hold leaders accountable? And because if every leader walked the talk and followed the IHR regulations and all things that have been outlined for response to the pandemics, we would not be here to begin with. So how, and it's not only about this pandemic, but for the next pandemic, and also how do we get quickly out of this, the mess that we are right now with due to the current pandemic. So just want to kind of impose that question because it was a common theme on the answers that they both provided.
Sarah, can I just quickly?
Yes, please go ahead and answer. And
All right,
after
I'll try to
Alicia,
be
anyone
very
else
quick
can come
so I
in.
don't monopolize. In the United States, there's a very pretty well organized civil society campaign in respect of these issues, again, with the Biden administration and also members of Congress. I think, as Diane pointed out, there is a general lack, and I should say that Dr. Fauci is on record saying that he believed in the COVID technology access pool to get access to these technologies out more quickly than just through COVAX. And the Africa CDC is obviously gone to that boat as well. But I want to echo what Diane was saying about the lack of transparency and access that civil society has to all the decision making, not just at the WTO, but at COVAX and CEPI. So that is an important obstacle to really addressing these issues, in my view.
If I could add briefly, and thank you, Tsion, for raising the question. If we think about accountability, we can think of accountability in many levels. We can think of political accountability, domestic political accountability, and also think about international legal accountability. There are mechanisms that do permit, there are clauses compromissoires in, say, the WHO Constitution that can enable states to refer a question to the International Court of Justice as a matter of interpretation and application of the WHO Constitution. I quite like Carter's strategy of pinning states back to what they have signed on to, what they've already agreed to. But I'm the last person who's going to say, let's use the stick immediately. I often think we think of accountability in degrees of gradation. What can both incentivize states to act, and what can also ensure that counterpart states, the recipients, because in this respect, it's not as if when we talk about developing countries, they're a monolithic victim. If anything, the populations, yes, certainly can be considered victims, but there are also very challenging situations of corruption, challenging situations, morally hazardous behavior, crimes and fraudulent behavior in some instances that also have to be dealt with in infrastructures that are challenged in a governance sense. So I would look at accountability from a spectrum and examine the strategies of what do we aim to hold accountable. For me, my immediate concern is to make sure that trade rules do not become the impediment to the faster distribution of the vaccines or the access of the vaccines. I agree with Alicia that COVAX has been quite a dismal failure in many respects, because much as it set a bold ambition of getting 2 billion doses by the end of 2021, they've only signed on approximately 140 million doses from 2 of the producers. They do have supply agreements in place, but none of us can see what those supply agreements are. There's no monitoring actually of what the actual vaccine levels are that are being warehoused in any particular country or participating entity in COVAX. So my challenge for this is, much as people will criticize the vaccine producers for not doing enough, there's also a problem with the international system not doing enough itself to stand by its own commitments of transparency and accountability. And unfortunately, in the COVID-19 situation, the World Health Organization has had quite a number of lapses. And so admittedly, it has not enjoyed as much of the global support that it ordinarily would have had as in previous outbreaks, simply because its own behavior has also been less than pristine under the circumstances.
Thank you for that, Diane. And I think, so the lapses in the international solidarity, people not coming together, and there are countries that we've seen that are obviously prioritizing their citizens at all costs. It's been a one man for himself and God for us all situation. But I want to move now to John and say, what should the wealthier countries then do to balance not only the needs of their citizens, because we can't deny that as a government, you have an obligation to your citizens, but then they've also signed on to treaties where they've agreed to have obligations towards the international community and citizens in other middle-income countries that require assistance.
Well, thanks so much, Sarah. I really appreciate the opportunity to be here, and thanks. First, just want to thank everybody at the ECK Institute for putting this together. And I just one other thought before trying to respond, hopefully to your question is I really resonate with the previous panelists. I think these issues around transparency, representation, the challenge, frankly, of international law and its functionality in this case, I think are real. And I guess I think Carter, your experience certainly resonates with my own in representing the United States at the WHO or with the Global Fund to fight AIDS, TB, and malaria. But I really want to echo Alicia's point. I think if you want to change the political equation for governments that have a set of sort of consistent interests that they're representing, the HIV example is the most powerful one in the sense of civil society mobilizing, and what that looks like in this environment, it's hard to know. I do think a lot of the work that Alicia and her colleagues are doing are important to move these issues, at least in the United States, and I know it's true in other countries, to the top of wealthier countries' political agendas. So anyway, I think this is a really terrific conversation. So let me try to offer just a few thoughts, and maybe we're going to help the conversation. I mean, I think from the initial point, I think from an ideal perspective, and if you view sort of moral obligations or legal obligations from a global lens, and you've based on principles like solidarity and the dignity of each person, sort of in their rights, no matter where they live, you would imagine a system, either a shared system or some sort of global mechanism that would exist not only in this crisis, but would be thinking about how do you incentivize R&D, how do you maximize manufacturing capacity, and then how do you run a distribution mechanism, at least with a global perspective, so that we'd be thinking about vaccines going where public health principles would call them to go and where equity requires them to go. And you think about priority, like Tedros said, you would be thinking about priorities from a global standpoint and not a country by country standpoint. But of course, that's not the world we live in, right? So, and I have to admit, the flip side of this, I do have some sympathy for, from personal experience. During H1N1, I was involved. I worked at the Department of Health and Human Services, and it is very hard in the midst of a real pandemic when you're a democratic government to balance the needs of your constituents versus needs of people in other places, or it's and we need democracies to deliver. So I have sympathy for it. I have sympathy for the conundrum that the Biden administration is facing right now. So it doesn't mean that I agree we're in the right place, but I think we have to, if we're trying to find practical solutions, we got to understand the domestic political drivers that countries are facing. And so I guess I thought maybe I was thinking of sort of three arguments that we could make in wealthier countries that at least would argue against some of the more extreme forms of vaccine nationalism. And so maybe this is helpful. One is, public health. I mean, I think it's really important to not forget that we have to remind policymakers that vaccinating a large portion of your population is not going to solve your public health problem. Variants, people are going to always be unvaccinated. The spread of a global pandemic is a threat to a country, even if you have a huge percentage of your population vaccinated before others. Second is political. We need to also remind people that vaccinating large percentage of the population is not going to turn life to normal. Commerce, travel, international economic activity that matters a lot to wealthy countries. Getting people, I mean, the reason that, the political imperative is overwhelming, but it's just solving your domestic problem is not going to solve the economic and the social problems that the pandemic causes. So we need to keep making that argument that there's more that has to be done. And then third is, I think you do have to tackle the moral issue here. And there clearly are ethical principles that allow communities to think about their own members first on some level. And there's principles like Catholic universities sponsoring this, principles like subsidiarity let you think about your local actions taking some priority in addressing major problems. But I think we got to push back on any of those ideas. Those ideas are fine, but they can't be allowed to go too far. And so the moral counter argument, I would say, is that we have to ensure that nobody accepts a moral perimeter, that there's some set of people that are beyond our moral concern. And I think you can win that argument. That doesn't mean you get yourself to an ideal world, but I think we really have to push back against the idea that anybody is beyond our concern in this moment. So the question is then, if those arguments might have some resonance, what to do? And I hear Alicia and others noting the weaknesses of COVAX, and it's certainly not perfect, but it is a new innovation in our global architecture, and it sits right in front of wealthy countries, and it's something that they can and should do, even if there are other things that they need to do better. And I guess I would start, I think it's hard. The strongest political argument is we have a problem and there is at least the beginning of a solution. And I agree that we need to look also at patent pools and other mechanisms to share IP and to incentivize manufacturing. But one thing we know every wealthy country can do right now is fully fund the first round of commitments to COVAX. And I'd rather get them started than to do nothing. And I do think one advantage of this moment is COVAX has, again, I know there are transparency issues, there are other challenges, but if it could start to succeed, demonstrating that there's some success in moving vaccines to needy countries, at least somewhere along the timeline that's going on in wealthy countries, I think is a really important step. So let me stop there. I hope those comments are helpful.
Sarah, can I ask you a quick question?
Sure, Carter. Before you do, I just want to remind all the participants that there will be a Q&A, so continue to let your questions come in, and then we'll address them the last few minutes of the panel. Go ahead, Carter.
Yeah, no, this is just for our audience, our viewing audience. I'm not sure, maybe I missed it, but I'm not sure that we defined for the viewing audience what COVAX is. If John could say what that is and what it's being funded, it just gives some further background context.
Oh, sure. I'm sorry. I thought that it had been framed at the beginning. My apologies. COVAX is let me step back even further. There's a thing called the ACT Accelerator, which is a partnership between WHO, Gavi, which is the global vaccine alliance that's focused over the last 20 years on essentially using mechanisms to make vaccines affordable for low-income countries. There's an organization called CEPI, which has an even more complicated name, the Coalition for Epidemics Preparedness Initiatives, which was founded just a couple years ago. That's looked to support R&D for vaccines, for vaccines against diseases of pandemic potential. And then there's several those organizations and several other, the World Bank and others have various affiliations with this ACT Accelerator. The idea of the accelerator is to focus on diagnostics, therapies, and vaccines that could address COVID. And again, in you know better than anybody, Carter, the alphabet soup of this space. So then the vaccine portion of that is called COVAX, and it is co-led. It has three leaders. It has CEPI and Gavi and WHO, and their job is to create. They have proposed a mechanism, and there's a lot of complexity to it, but a mechanism whereby countries will pool resources and sign up to essentially access vaccines. And then part of it is to give countries opportunities to access vaccines that they might not be able to get access to themselves. But the big benefit of this is to provide vaccines for a portion of the population in the 92 lowest income countries. And the target they have is, it was mentioned earlier, is sort of 2 billion vaccines doses by the end of 2021, which would be very hard for them to accomplish. But the idea is to provide if they succeeded, it would provide vaccines for up to 20% of the population in these lowest income 92 countries, plus other benefits to other countries. Let me stop. If anyone else, I'm sure Alicia and Benjamin have, I think that's hopefully a summary that's useful for the audience.
Thank you, John. I think before we shift to Ben, I can see you've unmuted your mic. Tsion, I was curious, as someone who advises the Ethiopian government, COVAX, is it ensuring equitable access? Is it the answer to distributive justice from the perspective of the government that's in a low and middle income country and supposed to be the beneficiary?
I think John has put it perfectly. COVAX is really now probably one of the only way where we have a multilateral collaboration for ensuring an equitable distribution of the vaccine. Of course, as the other panelists have pointed out, also has its own shortcomings. But again, we really, as also my boss, Dr. Leah, who's the Minister of Health of Ethiopia, is also one of the co-chair for the COVAX distribution. The advocacy work and also trying to find through other source of vaccines to the African CDC and other private donations are some of the ways that we're trying to get access to Ethiopia. But again, I would also say that if you really think about just the whole content of sub-Saharan African countries, so much of the discussion has depended on COVAX. And I don't, especially if the rich countries can't commit to the 2 billion doses, we're going to be faced with the shortage of the vaccine. And unfortunately, looking at the distributions is just so gut-wrenching to see how some of the countries are probably not going to get the vaccine until 2023. Personally, as a physician working in the US, I was offered the vaccine the first week. And and this is something that I wrote an op-ed about, because I'm pregnant at the time, I just decided to take a week to get the vaccine. And now currently I'm in Ethiopia, and people have been asking me, you're probably the only person who's vaccinated that I know and will encounter for the next 6 months. And it's just been so gut-wrenching to me personally. And at the same time, simultaneously, and there are also people who have hesitancy about the vaccine in the US, starting from some of my colleagues. And I wish sometimes I could just grab some of the doses that they've refused and give it to some of the most vulnerable people here. So it's a personal internal battle that I just, battle with every day. But at the same time, we've had some promises through bilateral relationships to at least get 9 million doses to Ethiopia by April. But I would probably say also Ethiopia has had really good negotiating power with some of the strongest, also with some of the developed countries, and also with international involvement. And that won't be the case, especially for some of the states and some of the fragile states and some places that are also in the middle of war. So it won't be an equal distribution immediately, but so much of the discussion from Ethiopia and also other countries has been really relying on COVAX, but it also involves a lot of advocacy for most of the rich countries and the wealthy countries to contribute to that. And every time, now when the US signed, there was a big relief, but really are hoping to see that increase in the commitment of the doses, and also really hope to see the transparency. As we've seen, even the price gouging that we've seen for, I think it was for AstraZeneca, what was offered for the UK versus for South Africa, that is just unacceptable. You can't sell the vaccines at more prices than what you're doing for the developed nations. So I think transparency is something that is going to be very important with COVAX. And also to what John said, actually exactly a year ago at the African Union, Ethiopia was the only country from sub-Saharan African countries to sign up for CEPI. And the way how CEPI works is you have to put in some money for the research and development, and each country has to sign up for this. And through collaboration with the World Bank, Ethiopia was able to do so. Because of that, also we have the added advantage of the negotiating power. And this were not the things that, we've had so many discussions about pandemic preparedness in the past, but unfortunately, most of the countries in sub-African countries did not sign up for this, for CEPI and other resources that could have helped during this pandemic. So exactly a year ago is when we signed up for CEPI. So there are different channels, but of course, COVAX is where most of the sub-Saharan African countries are really relying on. And I do hope, I'm optimistic, but hopefully somewhere and somehow we'll be able to get the vaccine sooner than 2023.
Okay, great. And Ben, before I hand over to you, I just want to say as well, could you, after your remarks, could you go on and answer the question, what are the human rights at stake? I know that they've been outlined, but it might be helpful to kind of go over the human rights at stake in the issue of access to medicines and distributive justice in general.
Happy to do so. And thank you, Sarah, for bringing us all together and helping us to think about the ways in which we can frame the ethical norms around equitable access for a COVID-19 vaccine. My question coming out of John's presentation was that he raised this idea at the beginning that in many ways we're drawing on the HIV example. And I think a lot of us come to this question of equitable access from the HIV experience. And as we think about the extent to which that HIV model is applicable, we begin by thinking, as Diane discussed, around human rights advocacy. And when we think about human rights advocacy, and this goes back a decade, Alicia and I first began our discussions around this in 2010, thinking about the litigation-based response that civil society pursued when trying to advance the right to health. And the AIDS response was that it was an easier legal claim to make, that there were individuals who were sick and a specific drug or else they would die. Whereas here, when we talk about human rights claims, we're talking about access to a vaccination. We're talking about people who are healthy, but asking for judicial relief. And so we're limited in that respect. It also becomes it also raises limitations when we think about the WTO and when we think about international trade law, where the HIV experience led to the Doha Accord that sought to raise public health emergencies as an exception to patent protections under TRIPS. We now need to ask the question, in the Doha Accord example, we were looking at a situation in which there were select nations that had public health emergencies and were seeking exemptions. But now we're in a situation where all countries are facing the same emergency at the same time. So we're not just talking about a question of cost, we're talking about a question of limited access. And as we move forward, we need to think about the institutions that are being developed around COVAX and drawing on CEPI and Gavi's work, and how those will they become more like the Global Fund, where we develop a very charitable, benevolent, I think Alicia said, crumbs from the table response, where we try to pool resources for those countries. But as Tsion points out, those countries will always be prioritized last. And so transitioning from that question to thinking about human rights, my research bridges health and human rights, global health governance, and global health law. And these ideas all come together as we think about the role of human rights law in shaping global health governance for ensuring the progressive realization of access to a COVID-19 vaccine. And in realizing the equal dignity of all persons that Carter raised, what does human rights law require, as Diane asked, for equitable access to essential vaccines? Supporting access for the poor, the elderly, the disadvantaged, the marginalized, as a matter of rights and not simply as a matter of charity or benevolence. And so when we think about, as Sarah asked, what are the human rights at stake? When I say that there's access to an essential life-saving vaccine as a core human rights obligation, what rights am I referring to? I think we begin in the right to health, where vaccination has long been seen as a central element of that human right. This right to health, first codified in the Constitution of the World Health Organization, first embodied in international law under the International Covenant on Economic, Social, and Cultural Rights, and first interpreted in a post-Cold War context at the turn of the century by the UN's Committee on Economic, Social, and Cultural Rights in General Comment 14. We've sought to progressively expand our understanding of the right to health to the point where the UN Special Rapporteur on the Right to Health has found that based upon this progressive evolution, that nations bear an obligation to do all that they reasonably can to make sure that existing medicines and vaccines are available in sufficient quantities. Beyond the right to health, and by extension, the right to life, we can also see widespread access and distribution of a COVID-19 vaccination supported by a human right to the benefits of scientific progress, a right that was recently clarified by the UN's Committee on Economic, Social, and Cultural Rights to require that states provide resources to ensure access to the most advanced, up-to-date, and verifiable science available. As we think about how we translate that human right into global governance systems, we recognize that as we think about the systems we're setting into place, we're not only transitioning from the HIV movement, but we're also setting a precedent for the distribution of future prospective cures for HIV and hepatitis C, and our global governance response to many long-standing global health threats. And when we think about the obligations that this imposes on global governance, both through states that are members of these institutions, and also as independent responsibilities of these international organizations, how do we think about obligations to move as expeditiously and effectively as possible toward the full realization of the right to life, the right to access of essential medicines, ensuring, based upon the human rights framework, that these vaccines are available in sufficient quantities, that they're accessible geographically and financially, that they're acceptable, both respectful of medical ethics and respectful of culture and gender, and also of sufficient quality. Thinking about the ways in which these vaccines need to be scientifically and medically appropriate and of good quality, raising the issues of counterfeiting and other substandard vaccines that others have raised earlier today. And as we think about the implementation of these obligations to progressively realize access to a COVID-19 vaccine, we need to think about what this means for new forms of global health governance. And this is where I raised the question around HIV with John's comments. How do we think about global cooperation to guarantee benefits? Given that we are unlikely to eradicate this disease, can we draw on the same example of the WHO consistently raising vaccination and eradication of smallpox? Given the weaknesses that we've talked about in WHO, in CEPI, institution, and so I don't want to fault it too much, the COVAX facility, which we've not acknowledged is innovative but insufficient, how do we think about strengthening these institutions? CEPI, Gavi, COVAX, WHO, to facilitate availability of new drugs in sufficient quantities. How do we ensure accessibility by lowering the price and establishing equitable access, resolving some of the intellectual property concerns through the WTO, and building national vaccine capacity, recognizing that national capacity for developing vaccines is very different from national capacity for developing pharmaceuticals. And how do we develop, in thinking about quality, national frameworks to ensure quality through global governance and support what are called national immunization technical advisory groups to make sure that we can have consistent regulation of quality of vaccines across nations so that we can move effectively and efficiently as possible. And then finally, I want to close by thinking about global solidarity as itself a human rights obligation. Governments are scrambling in this vaccine nationalist moment, not as a unique response. In some ways, this nationalism and populism have been rising for several years now. Countries are hoarding vaccinations because this is in line with the normative frameworks that are guiding them across global governance. How can we think about global solidarity and specifically international obligations of assistance and cooperation as a way of supporting global health governance, of binding nations to not leave their human rights obligations behind when they step foot inside of these international organizations, but in restructuring these international organizations to realize human rights effectively across nations and to secure equitable access to a COVID-19 vaccine. Thanks.
Thank you for that, Ben. Because of our time, I'm going to limit a response to 2 minutes, and then we want to get into the questions because the audience that is watching us do have a number of questions, and I want to make sure that we have enough time to really get to those. Diane?
Sarah, if I may, Ben, thank you very much for the clear elaboration. I will simply add 3 extremely important human rights norms that cut across civil and political rights and economic, social, cultural rights, which also ought to be considered in our framing of the applicable human rights. And the first is the non-discrimination obligation, which is a key obligation that cuts across economic, social, cultural rights and civil and political rights guarantees. What we're seeing around the world is, to a large extent, the presence of vaccines, but a glut or a gridlock when it comes to access to these vaccines for a number of reasons, and it's not just based on resource. It's actually ending up becoming an issue of one's geography and where one's particular geography is under the circumstances. We've seen how the argument has been made that healthier people are getting access to the vaccine as opposed to those who are more vulnerable. So if there's something that the non-discrimination obligation can bring to the forefront of our query, is to examine how it is that the current mechanisms of prioritization for vaccine are being conceptualized merely at local levels without a corresponding coordination at the international level. I mean, that precise gap right there is what enables certain countries that have the resources to vaccinate their populations, their younger populations earlier, but not elderly or disabled or more vulnerable populations everywhere else. I think the non-discrimination obligation is implicated there. The second thing I'll also point out is the equality obligation, which is separate from non-discrimination because non-discrimination is supposed to be a floor. If we look at who is being vaccinated, from what race, from what gender, from what age in life, there's also intersectional considerations as to who's really among the vulnerable really getting access to this vaccine. But the human rights bodies and the special rapporteurs and the committees are not even beginning these queries yet, much as they have agreed that there should be equitable access to the vaccine. And finally, my own preference, given my own work with the UN Working Group on the Right to Development, is also to take a look and go back to the right to development, because one thing people don't understand with the COVAX facility is that in reality, this is a lot of development decision making being made by the private sector, by governments, by institutions for development, such as the World Bank. And the kind of allocations and prioritizations that are being made, as we've argued from the UN Working Group, ought to be consistent with human rights and fundamental freedoms. It's not just an anodyne conception of economic development, but rather one that ought to be premised on human rights. So I'll call attention to just those 3 important norms and hope that we can move forward in the discussion.
Thank you for that, Diane. Tsion, we'll end off with you before we get into the viewers' questions. There's just one more question. How can we ensure the right to health for people in low and middle income countries is protected at the same standard as the right to health for someone in a high income country? What do you think?
So when I read that question a few days ago, like, that's a difficult one. Especially as somebody that lives the bicontinental life, and also sometimes it's just very difficult even for me to comprehend what I do in those two different places. And I've seen it, especially when in New York City during the peak of the pandemic, as really how the pandemic has really made visible the inequities that exist even in places like the USA, where we have the highest amount of resources compared to most places that I see here in Ethiopia. And it's nearly impossible to protect the right of health for people in LMICs at the standard for wealthier nations. And this is all exacerbated because of the dearth of resources and lower and middle income countries. And also this idea of human rights, it's not really translated in the same way as what I've seen in the Western world, and also here, especially when it comes to other things besides health. But what I would say Ethiopia especially, we do believe that, health is a human right, and Ethiopia is one of those countries that is also trying to achieve universal health coverage along with the SDGs. And with the limited resources that we have in these countries, people have had equitable access, especially during COVID. I would say very proudly, most of the patients that have that needed medical care in hospitals in Ethiopia have had access to free care. And I even brought up the question of, like, some people that can afford, they've offered to give money or to give some sort of gifts. And compared to what I witnessed in the US, is really the government's role in ensuring that everyone, no matter what they come from, rich neighborhoods or rich families, and the same access to also to the vulnerable and the poor in the country. And I'll give you an example. Somebody who is a well-to-do family here got COVID, and at that time he went to some of the private hospitals that he was used to going to. But the private hospitals were scared of him having COVID. So they said, no, go to the public hospitals. And the public hospitals at that time, he started just going to his local health center. And overnight, they gave him oxygen until there was a bed available for him at the treatment center. And he said it was absolutely the best care he received. And people were not scared of treating him for COVID, for his COVID symptoms, versus in the private settings that he was used to. Unfortunately, they were not able to provide him the same care during this time. So I've been very proud of how, especially the response in Ethiopia has really made an equitable access to the care for COVID. And most of the panelists have mentioned, I was too young to remember what was happening at the decision-making table during HIV pandemic, but growing up here, I've seen how the lack of access to ARVs have affected many people in this country. And over the years, until PEPFAR and until we have civil societies advocating, and also with ARVs becoming available, it took almost a decade to see the decline in HIV in this country. So I really do hope that we've learned from that mistake, and that hopefully, with most of the statements that have been made at the UN and WHO level, never again, really the same thing also would go with this vaccine distribution. And just like I said earlier, the projection that most of the lower middle income countries might not get a vaccine to get to herd immunity until 2023, that is just absolutely unacceptable. It's not really just about the vaccine, right? When you have the vaccine, and I'm pretty sure Diane has mentioned it earlier, but also there's some economic consequences to that. We've seen how the IHR regulations were not upheld during this pandemic. So most likely if the disease is spreading in some of these countries, that's going to decrease access to tourism, a lot of their exports, and also their economic development. So it's really about a matter of their existence. And also, I think selfishly from a developed country, from a wealthier nations, we're seeing these new strains coming from different places. So if we don't vaccinate, also make vaccine available in a equitable manner in lower middle income countries, we're just going to be going in circles again. And also there's going to be more restrictions on travel and bans, and it's going to make more of the economic downside in most of the developing and most of the lower middle income countries. And of course, the bigger picture, whether it's during a pandemic or not, it's really about ensuring access to most of the population, and also by not adding a burden on their finances, which is universal health coverage. So universal health coverage is, I'm an advocate for it. It is something that we all strive for, even here in Ethiopia, and also hopefully over time it's something that we can do in the US. But really, it's one of the ways that we can ensure that people in lower middle income countries can have their right to health and access is protected at the same standard at the right of health in the wealthier nations. And I personally really do believe in multilateralism and really investing in what could hold us together. And really, hopefully over the next few years, we'll see, especially in the past several years, because of the because of the stance from the United States pulling from many of these organizations, we've seen how this has been fragmented. But now with the new administrations, and with the commitment, I'm really hoping that some of the collaborative efforts will come into reality, and that will be out of the mess we're in right now. Thank you.
Thank you, Tsion, for that. Yeah, what I particularly found interesting was how you flipped the issue of the right to health and access to equitable access to say that actually in an African country like Ethiopia, there might be far more access regardless of economic circumstances versus a developed country like the US, whether or not the poor can access the same quality healthcare standards. But obviously, that's a conversation for another day, but that's interesting to point out. I'm going to go now to the questions from the audience, and I'm just going to read them out. Panelists, please feel free to jump in. There's one question that says, I was hoping that the topic of human dignity would be more discussed as you had asked the panels. Carter mentioned intrinsic dignity, but in general, is dignity becoming just a word that is getting brushed over in discussions? So Carter, your name is in there. Sounds like you'd be the right person to jump in here.
Yeah, no, I'm happy to enlarge upon what I said before. So it was interesting in the experience that we had at UNESCO. This questionnaire was sent to all the member states, and they were literally asked just to list the ethical principles that were, or to actually they provided ethical principles and then provided a space for people to include new additional ones. But the one ethical principle that a massive majority of the responding member states chose as central and animating for their thinking about bioethics and human rights and health issues was human dignity. And of course, everybody knows the story about grounding, the Universal Declaration of Human Rights and human dignity. Everybody agreed that human dignity was really important, but things broke down pretty quickly when the discussion moved to a level deeper, like, well, why do human beings have human dignity, and why are people equal? Why do we have obligations? Who are we? How do we stand in relationship to these sort of first order anthropological principles or normative principles, anthropological in the original sense of what it means to be and flourish as a human being? And that's obviously a point of grave disagreement among people of goodwill, thoughtful people of goodwill. But the one thing, but I do think, just in the same way that solidarity is an abstract concept, appeals to the normative sensibilities of folks, that dignity is important. It's important as if nothing else, a kind of placeholder for the notion that our neighbors, our brothers and sisters overseas that we don't see and we don't maybe have the moral imagination to hold in front of us in our consciousness enough all the time when they're in need, and to feel the obligations that they have on us, that the concept of human dignity, of our intrinsic equal worth, which does not have geopolitical boundaries, is something that resonates across cultures and certainly across member states at UNESCO. I do think it's important to draw upon normative goods and to call them by specific names in order to, not just as a political matter of persuasion, but also just a moral suasion as well, and to remind ourselves our obligations to other folks, and to not simply think in a self-interested way, whether it's our community, our state, our nation, or our continent, or however you want to describe it. I think human dignity is a kind of an appeal to the intrinsic connections, unchosen obligations, and unearned privileges that we all have just by virtue of our common membership in the human family. And I think that it's important to speak in those terms, and to hold nations to account when they've made commitments, to encourage them to make commitments that are grounded in those goods.
Okay, great. The next question is, I'm thinking that the normative foundation for equitable distribution is very important. How can we translate this normativity to practical realization? So the norms that we mentioned, anyone want to jump in?
I just have a question to tee up my colleagues to make richer remarks, and this draws upon those of you who have had more experience in this area than I have. Are there, and Benjamin mentioned the HIV, the campaign to address those grave issues abroad. Are there precedents that we can look at where we did something right, that we can draw upon, both in terms of political persuasion, mobilizing collective action, and responding to those in need who are, usually beyond our consciousness? Are there good concrete lessons to be learned that my colleagues on the panel can point to, that we could look to for instruction?
Ben, it looks like you've unmuted. Go ahead.
I think everything is a mixed success and a mixed failure, and in some ways, maybe that's the best we can hope for. So if we try to translate this idea of dignity into rights, and I think you're good to point that out, that sort of dignity becomes this normative foundation of human rights, and human rights becomes the way after the Second World War that we seek to embody our commitment to equal dignity at birth by focusing on equal opportunity and rights. As the United Nations seeks to develop human rights, it also takes on responsibilities to implement those rights. And whereas we think of human rights as belonging to each individual, but to be realized by a state duty bearer, we begin to see a transition in a post-Cold War world to think about institutions bearing obligations to implement human rights through their own actions. And this gets embodied after the Cold War in Kofi Annan's push to mainstream human rights across the United Nations. However, we see each international organization implementing human rights in very different ways. And so one of the lessons that's coming out of this as we seek to strengthen human rights and global health governance is developing greater consistency and harmonization across international organizations, so that there's a consistency in approach to mainstreaming human rights in global health governance. And I think that this provides an opportunity for looking to past examples of human rights success, whether it's the International Labor Organization focusing on human rights and occupational safety and hygiene, whether it's about UNESCO focusing on human rights and advancing scientific education and medical ethics, whether it's about the World Health Organization raising the idea that access to essential medicines in the context of HIV is a human right. These are all different but complementary ways of thinking about what human rights mainstreaming can bring. And out of this, I think there's an imperative for different organizations to approach this in different, not in different ways anymore, but in harmonized ways that truly realize human rights.
John, and then Diane, I think you wanted to say something. So yeah, John, go ahead, and then Diane.
Oh no, Diane, I think Diane and Alicia had their hands up before I did.
Oh, okay. I think in terms of operationalizing, and especially in my own work, my focus really has been in operationalizing economic, social, cultural rights in every aspect of international life, even in trade, finance, or investment. I think we're past the time for thinking that there's a hard divide between the two. How do we operationalize it? It goes back to how we mobilize and how we advocate before the WTO for the implementation and the execution of trade rules. What exactly do we argue in asking for a waiver? A waiver had been issued in 2005 for essential medicines. I can't think of any other time when COVID vaccines are more essential than essential medicines at the present time. And so even from the power of persuasion, operationalizing human dignity as a felt reality can be framed not just as an argument, again, going back to what we said earlier, not just as an argument of charity, but as an argument based on self, based on our understanding of ourselves and who we are as individuals. I mean, even if we wanted to appeal to foreign policy practitioners, as Tsion was pointing out earlier, there are self-interest arguments to be made here. Also, with respect to foreign policy and states who are concerned about their diplomatic interests, the borderless nature of the virus and the fact that you want to abate the spread of the virus and its variants as fast as possible as a public health concern, the ongoing investments in economic partnerships that the developed nations have and which are currently experiencing not just a retardation, but if not a retrogression in developing nations where economies are going into a fast standstill with unemployment and continued economic consequences. There's a democratization problem because as economies suffer, and you find that, you know, developed nations if they decide to be hermetic, you're going to have a confluence of many countries who will be more susceptible to other ideologies outside of democratization, simply because democracies are not willing to live by the human rights commitments they're making for themselves and overseas. And finally, the moral leadership question is also important as an understanding of how to operationalize human dignity, especially at this moment for the United States that has made bold proclamations about its recommitment to the international system and its recommitment to human rights. Certainly, one of the most powerful signals it can make is to marshal the effort to lead the way, especially since it is the home of vaccine production, of efficacious vaccine production, to lead the way in this massively disentangling this vaccine access and distribution problem. I mean, operationalizing can be done at arguing it at the level of the WTO, arguing it at the level of national courts. But most importantly, I do think that at the state level, developed states have a signal moment today to speak to the world and say, this is going to be a different international system, that this moment for the United States, which proclaims the moral moment, this moral moment could also be translated to its solidarity and concern for the rest of the world beyond the immediate precincts of individuals and communities.
John, do you still want to come in?
Sure. I'm sorry. I would just say I think Carter asked the right question, and I, you know, which is, what does human dignity mean in this context? I think, you know, I guess it depends where you start. The world doesn't respect human dignity as a universal matter in most every way we're organized, right? And the world isn't the way it is by accident. So I guess I wanted, though, I do think that there's an opportunity for doing something positive to move from where we are to something. And Ben's exactly right. Every success is a partial story, right? And none of these institutions or structures are perfect. And he's right that the HIV litigation strategy, I don't think is applicable here. I was thinking more of just the mobilization, the energy. I do think there's a power to mobilizing people outside of governments. But I think I think that we can make some practical progress. It may not be all that we need, but it does seem that if we could make some progress on a sustainable mechanism, whether it's COVAX or some significant improvements to COVAX that can be available to distribute vaccines, not maybe as the level needed, but better than where it would be otherwise, that would be a real progress. I look back in history, to your point, Carter, the Global Fund is, for example, the Global Fund to fight AIDS, TB, and malaria is not everything, and it has its weaknesses, but it has accomplished a lot. That's an example. Gavi is another example of an entity that's accomplished a lot. Again, not without imperfection. So I guess I'm just thinking that in the time frame we're in right now, there have been some successes in global health that maybe we should try to move the ball forward. And it may not be, it certainly won't be all of what's needed, but boy, I think that's what I focus our energy, is to try to mobilize as much as we can on sort of near-term progress.
Alicia, given the time, we'll end with you, just as we began with you.
Okay, I'll try to be concise. So I don't want to be too critical, but I would say that human dignity is largely been honored in the breach in this pandemic as well as previously. I think the COVAX facility actually had remarkably, scandalously low ambitions to cover 20% of populations in low-income countries. Now, while I agree with John absolutely that vaccines are not the magic bullet in any way, shape, or form, in the global north, we would not tolerate such ambitions, especially when you consider that many of these vaccines were actually tested in countries in sub-Saharan Africa and other places in Latin America that are not going to have access to them. So I think one thing is to realize how sort of unbelievably extractivist and colonialist the current architecture is. The second thing, which was asked previously before we started this conversation, is why not use compulsory licensing and the TRIPS flexibilities that were achieved during the HIV epidemic. And the issue is really one of the way international intellectual property law works, because each country has to apply to use each flexibility separately for each product. And that, in the kind of landscape horizon that we're seeing now in COVID, is with evolving understandings of which vaccine works in which context, is just not really practicable, which goes back again to the idea of a TRIPS waiver and sharing technologies and know-how through CTAP. I think I would differ from Ben in saying that litigation, I think it's a misreading of the HIV/AIDS story to look at litigation as opposed to collective mobilization, because the two were used very synergistically. And we've seen in other cases where governments have been forced to actually produce vaccines for different diseases, including a kind of hemorrhagic fever in Argentina. So I don't think that litigation coupled with other mobilization is out of the question here. And I think it's probably will be used in many cases. But one thing that really sticks out to me is the idea that human rights can't just be reduced to appeals to governments to do things, right? To do things in an equitable fashion that respects everybody's equal moral worth. And that, because for any number of reasons, because of political will and because of political capacity, where many countries in the global south simply don't have the space, the fiscal space, or the capacity to respond to economic, social, and cultural rights claim. So it seems to me misguided to try to transfer that to international institutions and use the same kind of hortatory appeal to do this, instead of attacking the real structural issues. And intellectual property is only one of those structural issues, but it is a major structural issue that is a huge sucking of resources from the global south to the global north. So I think one of the lessons from the HIV movement, which is absolutely applicable here is that power, economic or political power, is never relinquished voluntarily. It is always taken, and we're unlikely to get charity from rich countries and from institutions who are basically sponsored by rich countries. So it really comes down to collective mobilization and struggle.
Thank you, Alicia. Your answer, I think, sparked another question. So I will definitely throw out one more question, just because I think it might be of extreme interest to the audience. So if litigation, certainly at the national level, is possible, is there a possibility for some sort of litigation at the international level? And this question was asking, can we equate this deprivation of, for example, the vaccine and other medical advancements to low and middle income countries? Could we count this as some kind of crime against humanity, or some kind of genocide? It sounds extreme, but that's the question, especially for the lawyers that are all here.
I can try and answer this question. I know genocide is a loaded term that is frequently used, but there are elements in the crime of humanity called genocide that requires a widespread systematic attack directed against the civilian population with genocidal intent, with the intent to destroy by virtue of the character or the particular identity of that population. So it wouldn't meet, at least for me, the legal threshold of what amounts to genocide. But I'm all for creatively thinking about how to hold governments accountable. And there are many ways to go about it. The climate change movement has done it, and the Human Rights Committee has done it. In other fora, has done it before national courts. I fairly expect it's just a matter of time before international lawyers also start thinking about what the duty of care is as between governments that do have the wherewithal and the resources and the international duty to assist under these circumstances. But it does require careful differentiation. I wouldn't irresponsibly, in the first place, I would ask what a litigation is bound to achieve. And if what we're going to achieve is greater access, great. But I don't quite see that happening immediately, say, with an International Court of Justice case. I would rather nip it in the bud and try to go the TRIPS Council route and try to get that waiver issued as soon as possible. That would, for me, would be more expeditious, and that requires more persuasion, negotiation, and diplomatic resolution, as opposed to the hard stick of an international adjudication at this point, just at this point.
Okay, anyone else with a few thoughts? Or Tsion is smiling. I don't know if that means she also has some thoughts on this. Yeah, go ahead.
I can appropriately give this to the lawyers in the room where my limitations are, so I can't follow that, but thank you.
Okay, no problem. Okay, we've come to the end of our panel discussion. A huge thank you to the panelists. Your diverse views, insights, opinions, experiences have richly added to this experience. Just to let you know, a lot of the people in the comments were also really grateful for your insights and enjoyed this panel quite a lot. Thank you also to the audience for your engagement and for your questions. And I'll bid you all a good day.